Yeah, I'm sorry. It somehow it was not good. I'm sorry, guys. Testing. Okay. So you guys should be able to hear me on the mic now. Let me. Okay. Testing. You guys should be able to hear me on the mic. Good. Okay. Hey, look at that. Class is almost over, but we are finally wired up. Okay. Mhm. Well, I don't know because I'm not familiar with European standards. But supposedly, um, the educational standards are supposed to be aligned between all industrial countries. That doesn't necessarily mean they are. And of course, you're only as good as your instructor. So it's um, it's a really subjective question. But on the surface, it may look like they're doing the same things. But nurses have the higher level of knowledge to be able to look at real and potential problems. That's not really something you can see from the outside. So even though it looks like the nurses are doing CNA work, that doesn't necessarily mean that they're not operating on that higher level that you just can't see. Yeah, they're doing the tasks that you can, but and in a lot of places don't use CNAs. The nurses do everything. Because remember that CNAs are the eyes and the ears of the nurses. If they don't have good CNAs, then the whole thing breaks down because you don't observe things, you don't report them, things get missed, that type of thing. This is why we don't typically use a lot of CNAs in an ICU setting because I can gain a lot of information about my patients by giving a bed bath. I can observe their skin. I can observe their pain tolerance, how their breathing changes when I turn them on their side. There's a lot of things that I'm assessing while I'm giving that bed bath. So when we have critical patients, a lot of times we don't use CNAs. We want those nurses to do that hands-on care, to have that time with the patients so that they can pick up on all of these little things. So, and that may be the situation that you're describing, is that the nurses are doing this routine CNA type work. They're not doing nursing stuff, but they may be doing nursing. You're just seeing the CNA tasks. Okay? right, we are up and running. Yay. Okay, so let's go to page 46. This is ambulate with a gait belt. Ambulate's just a fancy word for walk. That's all it means. So walk. So we are going to walk a patient. Doesn't sound too hard, does it? We are going to walk a patient. So our care plan tells us ambulate the resident at least 10 steps, use a gait belt or transfer belt. It's the same thing. It's just two words or two names. Same thing. Patient will be sitting in a chair at the side of the bed with shoes on. Patient is able to walk but needs assistance to stand. So that tells us everything we need to know about this. But I want you to remember when a care plan tells you how far to walk a patient, remember there's a return trip. Right? We're not just going to walk them 10 steps and leave them there. Okay, here you go. Just hang out in this hallway for a while. So it's going to be 5 steps in one direction and 5 steps back for the test. But they're actually going to give you a destination. They'll say, walk to the bookcase and back, or, walk to the table and back. They'll give you an actual destination because they don't want you, remember, where do they want to be? Home in their pool, drinking their Mai Tai. They don't want to be doing this all day. So they will give you a very small destination. This really isn't about the walking. This has everything to do with body mechanics and safety. And just a couple steps is all they need to see to evaluate that. Most of this is going to be putting the gait belt on, lifting the patient to a standing position, helping them sit back down, taking the gait belt off. Those are the things that really are super important in this skill. So walking a few steps and then turning around and walking back, that part, what they're grading is, are you watching the patient? Are you standing behind the patient? Are they your full focus? That's what they're looking at there. It's not, the walking part really doesn't have a whole lot to do with this skill. Okay. But there's a couple things that you need to know about this. This care plan tells us the patient is sitting in a chair at the side of the bed with shoes on. And that is really important, with shoes on. That means that we don't have to put their shoes on. They're good to go. But I do need to talk to you about a clinical setting, though, because slipper socks are not enough. And if you've ever been in a hospital, right? If you've ever been a patient in a hospital, they give you that stylish gown and those super comfy slipper socks, and that's what you're going to wear. And we don't think twice about it when we're a patient. We put the gown on, we put the socks on, and we're happy. We're wearing the uniform of the patient. We're where we need to be. But I want you to think for a second about those slipper socks, right? Have you ever seen people walking in a hallway with slipper socks? So what kind of things are on the floor of a hospital hallway? Okay. Sharp objects. Yeah, we use sharp objects in healthcare, and they could absolutely fall onto the floor. And let me tell you, if I've got a needle on this floor, you are not very likely to see it because it's got little speckles and lines. And those needles can absolutely blend in for sure. So sharp objects can be on the floor. Do you think patients in a hospital might accidentally have accidents every once in a while? So urine, feces could be on the floor. What about stuff on the from the outside world that we bring in on our shoes? Is that on the floor? Okay. So the patient walks around in these slipper socks through all the blood and guts and whatever else is potentially on the floor. And then they climb into bed with those slipper socks on. So now what's all over their sheets? Yeah, all those pathogens, everything that we don't want cozying up to us while we sleep. Now, this is even worse if the patient has a surgical wound, an incision somewhere, right? We cut the patient open because do you know what environment wounds are? Warm, dark, moist. So those pathogens that are now all cuddled up to you in bed are trying desperately to get into that incision. And this is a potential way for surgical site infections to happen. So when your patient is out of bed, out walking around, if their feet are going to hit the floor, we need shoes on them. Those shoes are there to help prevent injuries from sharp objects like needles, but also prevent contamination from this on the slipper socks that's going to get into bed with them. Now, a question I get asked a lot, well, what if the patient doesn't have socks? Or I'm sorry, shoes. What if they don't have shoes? Can I just walk them in socks? Well, that may help prevent slips. You know, the socks might, but they don't really do a good job with that either because the socks always spin because they don't have good heels on them, right? So they don't stay where they're supposed to. So patients always end up walking on the non-dot area of the sock. So they're not even good at preventing slips, but they're not going to help protect against pathogens and sharps. So we really shouldn't be walking somebody without socks. If you make an observation, what do you do with that observation? So if we made an observation that the patient doesn't have shoes, who should we report that to? The nurse, yeah. So unless you've got Tracy's nurse who rolls their eyes at you every time you turn, come up to the nurse's station, you should let her know, hey, patient doesn't have shoes. You want me to walk them? What am I supposed to do here? Pathogens, ick, on the floor, gross. The nurse can call the family. Hey, bring Harvey some shoes. If the patient came from a facility, we can call the facility and say, hey, we need Harvey shoes. If the patient is homeless and has no shoes, we can call the discharge planner or social services and say, hey, go get Harvey some shoes. He's going to need them when he leaves. Right? We've got resources, but I'm not going to use any of those resources unless I know that there's a problem that needs to be solved. So it's up to you to let me know that Harvey doesn't have any shoes so I can solve that problem. But in the meantime, Harvey still needs to walk somewhere. So a second set of socks to act as a pair of shoes, right? Helps provide a little more insulation barrier, something that we're going to remove before he gets into bed so those pathogens don't cuddle up with him. Second set of socks can help with some of our issue, not all. Best to have shoes, but if that doesn't work, second set of socks will. Make sense? But thankfully for us, this skill tells us right in the care plan, patient's already wearing shoes. We don't have to worry about it. But the test has to grade that you know this is important. So for the test, when you start this skill, you're going to look at the shoes and you're going to say, I see you have shoes on. Or are your shoes fastened appropriately? Or do your shoes fit well? Are they securely on your feet? You need to address it somehow. You don't want to say, hey, nice kicks. That's not, we're not going to do that. Okay, we're going to address it from a clinical setting. Good? Makes sense? So our rule here, how we remember this, is when the patient's feet hit the floor, we talk about their shoes. And you see that there in the first column on page 46. You have to say something about their shoes. Now, while we're on page 46, I want you to look at number 4 in the step-by-step. It tells us to wash hands, gather supplies. We've seen that before. We've done it many times. But the next sentence there is super important. You might want to highlight it or underline it or bring your attention to it somehow. But it says, make sure walkway is free of obstructions. It does not matter when you do this. You can do this before you wash your hands. You can do it after. Nobody cares. Nobody cares. But for the test, they're going to put something in your walkway. Remember, I told you the evaluators are going to give you a destination, tell you where to walk. So they would say something like, okay, you're going to walk the patient. I want you to walk them to the bookcase and back whenever you're ready. They're going to put something in your path without you even they're going to try to distract you and make you not aware that they put something in your path. And what they're seeing is, are you going to look around to make sure that your path is clear before you stand the patient up? That's the critical part of this, before you stand the patient. Because if I'm over here and I stand the patient up and then I go, oh, there's something in our way. Hold on a minute. I'll be right back. That is not what we want to do here. We have to stay with the patient once they're standing. So if you forget and you stand the patient up, you better sit them back down before you leave. Don't leave them standing. But it's much better to just look around before you stand them, see if there's any obstacles, and if there are, move it out of the way before you start. Okay, good. Does that make sense? Do not steer your patient around an obstacle. That is an immediate fail. Why? Why would it be an immediate fail to steer somebody around an obstacle? Okay, certain amount of steps. We didn't look. Okay, so it increases the likelihood of injury. Yeah. So when they're grading you, it's not about what did you forget, it's how is it going to impact the patient. And since that has a potentially serious impact on the patient, it increases the potential for injury. That's pretty important. Absolutely. Absolutely. You can say, and I would absolutely address this. In fact, somebody just emailed me over the weekend. This is somebody who has been watching our live. She's challenging the test. And for some reason, she wants me to teach her how to be a CNA over email, and I can't do that. But she keeps sending me all of these very long, detailed questions. And one of the questions that she had was about making corrections. So let me kind of explain to you a little bit about corrections while we're on the subject. When you're making corrections for the test, you can talk to the evaluator. You can tell them, correction, I need to start over, whatever. But that's really not how it should be done. Who should you be talking to? The patient. Now, here's why that's important, okay? In a clinical setting, they want to know. So let's say when you go to work, right, and you make a mistake, are you just going to ignore the mistake and hope nobody catches on, or are you going to fix it for the patient? Now, this shows ethics and integrity, right? So at the end of the skill, you realize, oh my gosh, I steered the patient around this. What you should say is, I'm so sorry, Miss Jones. I don't know where my head was, but this was a fall risk. I would like to walk you again, but I want to make sure that we do it safely. So I'm going to go get the gait belt. Let me start over because I really want to make sure that you get a good quality walk in that's safe, that meets the needs of the care plan. Trust me, those evaluators, they're going to follow right along. They're pretty smart cookies, despite the Mai Tais. So they'll catch on and they'll say, okay. So you can do that. There's no problem with that. If you did it the other way, evaluator, I'm so sorry. Don't know where my head was. I'm testing. So apparently I'm brain dead today, but I would have moved the table before. Let me show you how I would do that. That's okay. I mean, they're going to grade you. That's okay. But the first way shows that you have enough integrity that it's not about you. You're making sure that the patient's needs are taken care of. I want to walk you again to make sure that you get the appropriate walk safely. Okay, puts it right back on the patient. Does that make sense? Okay, so you kind of have to rearrange your thinking for the test. It's not about you. Test is never about you, ever. Yeah, you're trying to get two pieces of paper behind you, Tracy, two pieces of paper that say you passed. Yes, I know why you're there. You think it's about you. It's not. Test has nothing to do with you. Those evaluators in their mind have put their grandmother in that chair. They are watching you take care of their grandmother. So what kind of care do you think they're looking for? The best care. Okay. So if you were talking to them, is that really providing the best care to grandma? So let me bring this all together for you so you guys understand why this is important. When you are out there working, right? When you're testing, nobody likes to be tested. Nobody wakes up on testing morning going, woohoo, I get to be watched doing skills. This is awesome. That does not happen. Everybody is scared to death to be judged. Every single one of you has test anxiety. That's not a new thing. You are not unique in this. People during testing day will be throwing up in the parking lot. I am not kidding you. Test anxiety is real. I get it. I get it. And it's easy to make it about you because you're the one throwing up in the parking lot. How can it not be about me, right? I get it. But in a clinical setting, do not think that testing day is the only day that somebody's watching you and you're being judged. In a clinical setting, you are being judged every single day by the people that matter, your patients and their families. Those are the ones that matter, not the test. So you don't think that, the niece is going to be watching what you're doing with the uncle? Oh man, she is going to be all over that. Well, wait a minute. Why didn't you put his shoes on when you were walking him? What if he slips and falls and breaks a hip? Why are you feeding her and she's not sitting up straight? What if she aspirates and dies? You think the test is hard? Those families, way harder, because for them, it's real. It's 100% real with 100% real consequences. So when you're thinking about the test, you're going, oh my gosh, I don't like to be judged. I don't want to be watched. I've got to demonstrate this and I want to pass and I want my CNA and you've missed the point. Because out there, the place you're trying to get to, you're going to be judged by people 10 times harder than those evaluators are judging you because they don't understand medicine. So everything you do, they're going to think you're doing it wrong. 10 times harder. At least the evaluators, they're nurses. They know what you should be doing and they know why you should be doing it. Those families may not. So we got to make sure that we're doing this well enough that those families are going to think that their family members are in good hands. That's what the test is about. It's not about you. It's about making sure you have the skills to keep those patients safe when their family members are watching and when they're not. Does that make sense? Different way of looking at it, guys. Your skills being watched does not end at the test. That's where it begins. And those evaluators are way easier than what you're going to see up there. Way easier. Man, when my family's in the hospital, oh my gosh, I am that family. I am absolutely that. I am the one that's sitting by the bed when my mother has an intestinal abscess and I don't know if she's going to make it. And you walk in that room right by the sink. I am that family member that says, I'm sorry, you are not touching her unless your hands are clean. Please go wash them. Oh, I use hand sanitizer. No, C. diff is in the building. Go wash your hands. I do it to doctors. I do it to nurses. I do it to physical therapy. I do it to transporters. And don't think I'm not going to do it to you. I am that family member because I happen to love my mom. And now that my dad has passed, she is all I have left. I am an only child. When she goes, I'm in trouble. There is no more family. You don't think I'm holding on to her for dear life? That's the important part of this. That's who you're doing it for. Does that make sense? Okay. So, to answer your question, if you get through the skill and at the end you realize, oh my gosh, this is in my way, I steered her around it, that's probably not safe. I don't want you to think about it from a pass or fail standpoint. I want you to think about it from a what can I do to help the patient standpoint. Now, I tried to type all that in an email. Pretty sure some of it got lost in translation. But that's what we're doing this for. Okay? Never lose sight of that. That's what we're doing this for. And no, they do not like to see me in the hospital. She gets good care, though. She gets really good care. Okay, so let me explain to you a little bit about why we're doing this. Oh, candy shelf. Nice. Okay. So have you guys ever seen an old person trying to get up out of a chair? Anybody ever see this? Let's see here. Can you just spin that around a little bit with the handle? Towards me, yeah. A little bit more, a little more, a little more. Good. All right. Thank you. The thing that I was going to order doesn't, it won't do what I need it to do. So now I'm on the hunt for a new camera panning thing. Okay, so let's talk about an old person trying to get up out of a chair, right? When I want to stand up out of a chair, because I have enough strength, right? I just stand up, just like you do. But as your strength decreases, effort has to increase. So older people, a lot of times when they try to get up out of a chair, they don't have the strength to lift their whole body up. So they end up doing something like this. We call it the rock and roll method, right? So they start to rock because they're looking for momentum. And then they roll out of their chair and then they make it and roll back. So, oh, no. Start rocking again. How much energy did that take? Oh my gosh. A ton of energy. Now, we don't really care because they're old, right? What do they have to do? You know, I mean, they've got all day and nothing to do. So we don't really think much about energy with the elderly. But we have to understand that our energy levels decrease as we age. And we're all kind of aware of this, right? But I want to make you a little bit more aware of it. Have you ever seen a 2-year-old? Oh my gosh, they're awesome. They're adorable. I love 2 and 3-year-olds. My favorite creatures on the planet. Yeah. If you watch a 2 or 3-year-old, they will bounce up and down for no reason except that they have excess energy. They will just bounce, right? When was the last time you bounced for no reason? Like, if I win the lottery, I'm bouncing, but I got a reason and it's short lived. Okay. So they have energy to spare so much that they do all kinds of activities that are needless, right? Well, I'm going to tell you that your energy level actually peaks around 2 or 3 years old. And I'll prove it to you. You ever see a 12-year-old? 12-year-olds are awesome. Love 12-year-olds. And they got all kinds of energy. They can play basketball. They can skateboard. They can stay up all night playing video games. Awesome. Put that 12-year-old in charge of that 2-year-old for one day. Who wins? 2-year-old all day long. All day long. Your energy level has decreased in that 10-year time period. I'm telling you, between 2 and 3 is where you max out on energy. Sure, absolutely. Yeah, yeah. They do take naps, yes. Yes. But even if you take a nap, you'll never have the same energy level as that 3-year-old. You just won't. So let's go out now to like 22. So we know 2-year-olds, lots of energy. 12-year-olds, a little less. Still a lot, way more energy than I got, but a little less. Let's go out to 22. Now, 22-year-olds still have tons of energy. You can shop till you drop and still go out at night looking fabulous, right? Still tons of energy. Party till 2 a.m., right? Get up and go to work the next day, groggy, but you're there. Still tons of energy, but you don't have the same energy level you had when you were 2. And I'll prove it. Watch a 22-year-old, watch a 2-year-old and go, God, I wish I had that energy. Let's go out to 42. Now, 42-year-olds will shop till they drop, but there's no going out tonight. Sorry. I'm done. Now go out to 62. Now, 62, we're putting our feet up before we make dinner because we need that little break. Right? We're thinking about retirement because there just isn't enough energy to keep up with our normal household tasks and work full time. So we're thinking retirement. Oh. Just wait, it gets better. Now go out to 82. What kind of energy levels do you think you're going to have at 82? Very little, because we've noticed that our energy levels drop throughout life. Now, if you remember at the beginning of this, I told you that when strength decreases, effort has to increase, right? So if we have very little energy, and of course we have little strength because our muscles decline. Remember, all of our factories are on board. Our muscle strength is declining. So if we have very little energy and very little strength, that's going to be a problem for us. Now, a lot of times we're like, who cares? They're old. You know, what do they do all day? We don't really care. But what do we do that takes energy on a daily basis? What do we do? Okay, work. What are ADLs? Give me a few ADLs. Okay. Okay. And it goes on and on and on. And those are all absolute daily tasks, but those aren't really ADLs. Those are daily tasks. But ADLs are more like bathing, dressing, grooming, eating. Anybody ever been too tired to eat? Yeah. So we know if you're too tired to eat, automatically that tells you eating takes energy, right? What about talking? You ever been too tired to talk? Every Monday when I get home, because I talk nonstop on Mondays. Never? No, I am. When I get home on Mondays, my husband knows I'm not really up for conversation. I'm kind of done. Part of that's being an only child. I didn't have too many people to talk to. I never got the gift of gab, right? Didn't have to fight anybody for attention. It's all mine. So, yeah, you can be too tired to talk. You can be too tired to eat. You can be too tired to bathe or to get dressed. So, if our 80-something-year-old person who only has this much energy and they have to get up out of a chair, and it takes a lot of energy to get up out of a chair, and think about how many times we have to get up out of a chair to bathe, to groom, to dress, to toilet, to eat. That's a whole lot of getting up and down. Well, if all you have is this much energy and you can't import any, no matter how hard we try, Red Bulls just don't, they don't do what they say they're going to do, right? Right? If this is all you've got and you got to get up out of the chair that many times, eventually something's going to go. Either you're not going to get up, or you're not going to go have dinner, too much work, or if you get there, you're just not eating, or you're saying no thank you to that shower, or I just don't feel like getting dressed today, right? Things start to fall. And what do you think is going to happen tomorrow if they're not eating today? What happens to tomorrow's energy? Yeah. So this can end up with this cycle: less energy, less eating, less energy, less eating, less energy, less eating, less energy, less eating. And we end up premature. That's right. We call that failure to thrive. And it does happen. So this seems like a very simple skill, right? We just walk somebody 5 steps and back. That's not what the skill is about. The skill is about recognizing that our effort, sorry, that our efforts help the patient with their overall quality of life. Because if we help a patient stand and help them walk, that conserves their energy so that they can participate in social activities or in eating or in bathing, things that improve their quality of life. So what we're going to do is help offset their lack of strength by giving them some of ours. Does that make sense? That's what this skill is all about. We're lending them some of our strength so that they can keep up with their daily tasks. That's all this skill is. But I've got to show you how to help somebody to stand and help somebody to sit without putting them in jeopardy. Okay. So we're going to talk about a gait belt because our care plan tells us to use a gait belt. It's also called a transfer belt, 2 names, same thing. This is a gait belt. It's a flat canvas belt. These are placed around the patient's waist, not around yours. This goes around the patient's waist. Now, a lot of CNAs will wear it around their waist just to carry it around, and that's okay. But this goes around the patient's waist to help them stand. It does not matter whether the buckle goes this way or the buckle goes this way. Nobody cares. What matters is the tag is on the inside like every other article of clothing. Okay, just like every other piece of clothing. Now I'm going to put this on me just to show you. Remember, this goes on the patient. You put this around the patient's waist, their natural waist, and you want to make sure it doesn't twist as you're putting it on. It should be flat. So it goes around the patient's waist. And once you get it around the waist, you're going to put the free end here through the first guard by the alligator teeth. So it goes in the first guard. Now you pull it the way the teeth point. See how all those teeth are all pointing that way? You pull it that, if I try to pull it this way, it's not going to go anywhere because the teeth catch it. So I want to pull it the way the teeth point, and you need it snug. We get skinnier when we stand up. So if you don't have this snug, when the patient stands up, it's going to fall. Or if it's not snug as you're lifting the patient, it'll go up under the breasts or under the arms and injure them, or they could just slide right out. So you want it snug so it stays in place. We don't want it too tight though, because then the patient can't breathe. So how do you know when it's snug enough, but not too tight? You take 4 fingers and put them under the belt, between the belt and the skin. You should be able to fit 4 fingers in there. If you can fit a whole fist in there, it's too loose. 4 fingers between the belt and the patient. That's the right snugness. And once you get it in place, you're going to put it through the second guard to lock it in place. Now this tail, if it's hanging down, might be in your way. You can just tuck it into the belt to keep it secure. Good. When you're removing the gait belt, you're going to reverse the process. So you take it out of the second, and you want to hold that belt the way the teeth are pointing. So see how I'm holding it over in this direction? Then you take the buckle and slide it across the belt to take it off. Don't pull this. Listen to that sound. That can cause a burn against the skin, that friction. So you don't pull this out from under or behind a person. You either want to bring your hands around back to collect it, reach around the patient, or you can loop it up and over. Make sure you're holding on to the buckle so it doesn't bang them in the head. Okay. The big thing is don't slide that belt from behind the patient. Good. Questions? How do you know that this is snug enough? They need to see that for the test and preferably hear it. Okay. Now let's talk body mechanics. Oops. So we used to, years and years ago, we used to teach people to stand in front of a patient as you're lifting them. So knee to knee and toe to toe. And what that does is it keeps the patient's feet from sliding out. Okay. Toe to toe, knee to knee, keeps the patient's feet from moving. But there's a physics principle that you guys might be familiar with. Every action has an equal and opposite reaction. You guys ever remember hearing that in school? So if I'm lifting somebody, let's just say they're 150 pounds, okay, and I'm standing in front of them and I'm lifting them toward me, that means that I've got 150 pounds of force that's going to be trying to push me backwards. So my back is going to have to try to stop that from happening. That's a lot of force on my back. Now imagine it's somebody even heavier. That's a lot of force on your lower back trying to keep you upright when it's moving forward and you're attached to it. So what ends up happening is when you're lifting somebody toward you and they're trying to force you backwards, you will either become very unsteady and start to fall, which could take them with you, or your back is going to have a whole lot of force there to try to stop that backward motion. And this is how back injuries happen with CNAs. That's the number one reason that CNAs leave the industry is back injuries. We want to try to prevent that. So standing in front of somebody, not a good idea. But there is a better way. Okay. So if I'm sitting in this chair, I know you guys can't see this at home, I'm sorry. But if I'm sitting in this chair, turn back a page, you'll be able to see what I'm showing you. You can actually see a line in front of my feet. You guys see the line on the floor in front of my feet? The tiles? And there's a line on each side. So I am sitting in a box. You guys see that? Lines make a box. Now I'm going to use that box for body mechanics. So imagine my feet are here, okay? If I were to lift a patient up, I'm going to put one foot in front of their feet. That keeps it from sliding out, perpendicular or across in front of their feet. The other foot goes parallel to the chair. So I'm standing at the corner of the box, 1 foot along each side. Now when I'm going to lift the patient, I bend at the knees, not the hips. So we're going to bend down like this, reach around behind the patient, grab the gait belt, and lift. And when you lift, you are no longer being pulled backwards because you are at an oblique angle. Works with tall patients too. If you watch my video, the person who's the actor, he's about 6 foot tall. I'm not. So yeah, it works with tall people too. Okay, good. Make sense? So body mechanics is actually super, super important for this skill. We're going to get that oblique angle, grab the gait belt, and on the count of 3. Now that's super important. We need to count to 3 or give them a cue of some sort because it says, our care plan says they need assistance to stand, but they can walk, they can support themselves. So we need them involved. I don't want to do all the work here. They need to be involved. Otherwise, if I just lift them up and they're not involved, What happens when I let go? Yeah, because they weren't involved. They did not engage their muscles. This is a problem. So we need them involved. So counting to 3, I'm going to lift you up on the count of 3. Ready? 1, 2, 3. Okay. That way they are involved in the process. Super important. Now, when I go to sit somebody down, an essential step when you're sitting somebody down is that they know there's a chair behind them. If you're trying to sit somebody down and they don't know there's a chair, are they going to trust you? I have no idea. So right now, I have no idea where that chair is. I am not going to sit my butt down because I don't know if I'm going to make it or not. I actually need to know that that chair is there. And the best way for me to know it is to feel it with the back of my legs. That way I know there's a chair. Now I'm comfortable sitting down. You need to do that with your patients as well. When you're getting ready to seat a patient, doesn't matter where you're sitting them, who they are, what they can do, that has no bearing on this. When you're getting ready to seat somebody, you need to say, I need you to back up so you can feel that chair behind your knees. Let me know when you can feel it. Okay. Good. So all of that goes into a 2-minute skill. That's a lot of stuff to remember, but the skill itself, super easy and quick. So I need somebody, a volunteer, somebody to come sit in this chair for me. Come on over. Just go ahead and have a seat in the chair. Now for the test, the chair is actually going to be right next to the bed, like right next to the bed. That way, at the end of the skill, you can give them the call light, they can reach it. Now, in here, I've got it out a little bit just for visualization so you guys can see a little bit better. But remember, for the test, the chair would be next to the bed, so the call light, we're going to pretend. Okay, here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great. Feel like going for a little walk? Okay. Let me go close your curtain. I'm going to wash my hands and I'll be right back. I have clean hands. Get my gait belt. Okay, I see you have shoes on. Do they fit well? Good. And are your feet flat on the floor? Yep. Okay. Now that's kind of important. Now she's taller, so she sits her feet on me. My feet never are flat on the floor. I have to sit forward in the chair a little bit for my feet to be flat on the floor because I have shorter legs. So you need to make sure, are their feet flat on the floor? Okay. All right, I'm going to put this gait belt around you. This is going to help. I lost my words. This is going to help me lift you to a standing position and provide a little stability while we walk. Okay. All right. So now I know that there's an obstacle in my way. Okay. I did not move it during my opening. You can move it any time before you stand the patient up. But if I stood the patient up, which is what I was about to do to show you, if I stood the patient up and looked around and saw that, what would I need to do? Sit her back down. Okay. So Ms. Jones, let me move that and I'll be right back. Okay. So I'm going to put the gait belt around you. Can you lean forward for me? Thank you. Okay. Relax. We're going to put it through the first guard. Snug it up. 4 fingers. Through the second guard. Okay, can you bring your feet together? You're going to put your hands on my shoulders and I'm going to reach around behind the gait belt. And on the count of 3, we're going to stand up. Okay. Okay. When you stand, I'm going to help you stand for just a few seconds to acclimate. Okay. So 1 foot in front, 1 foot beside, put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. Good. You feel that stability? Okay. Just relax for a second. Let me know when you're ready. You're going to lead. Walk like you walk. You're going to walk to the bookcase. Are you dizzy at all? Okay. So at your pace. Now I'm going to walk slightly behind and to one side. Okay. We're going to stop and turn around. Still feeling okay? Yeah. Okay. We'll walk back to the chair. And good. Still feeling all right? Yeah. Okay. Turn around and back up so you can feel that chair. And I'm going to help you sit the same way we stood. Now notice how much looser that gait belt is. We get skinnier when we stand. Put your hands up here on the count of three. 1, 2, 3. There we go. Are you comfortable?
Yes.
Okay, I'm going to loop this around. Is there anything else I can get for you on here? All right, call light's right here. We're going to pretend you can reach it. There you go. Environment is clean. I'll put this away. Open the curtain. Wash my hands. Now look at the gray box in the first column. Let's go through that really quick and make sure that I did everything and see if I need to make any corrections. What is number 1? Did I do that? What about step 2? Did I talk about her shoes? Okay, number 3. Okay, so I placed the gait belt. 4. Okay, so I'm pretty confident here. I don't have to make any corrections, but if I did, who would I make them to? The patient. But I'm good, so my skill is done. Thank you. Do you see how those gray boxes can help you at the end of the skill? It's a great way for you to be able to kind of think about your steps in a shorter format.
Is the gray box gonna be?
Nope. Nope. That would be too easy. So that means that you have to memorize those gray boxes. That once you've seen the skill done once or twice, you really don't need all, 24 steps or, 24 steps, 28 steps. Okay, so yeah, it's a whole lot of steps, isn't it? 28 steps. So the gray box is just kind of a shortened, condensed version, assuming you know all of the steps. It's just to kind of spark your memory. It is a good idea to learn these. Flashcards will help you. Okay. Any questions on this one? This is a safety skill. Remember, safety is in the details. So this is a short skill. I mean, it took me 3 minutes to walk her 10 steps. It's a short skill. But the problem is it's a safety skill. So that means that all of the details are going to count. And they're going to count big. Moving the table, that counts big. Making sure they have shoes on, that counts big. Making sure their feet are on the floor, that counts big. Putting the gait belt on right, making sure it's tight enough that they don't slip out of it when you're trying to stand them up, that counts big. Making sure that they aren't dizzy, that counts big. Making sure that you're asking as you walk and paying attention to them as you walk, that counts big. Making sure that they can feel the chair behind them before they sit down, that counts big. Making sure you don't pull the gait belt out from behind them, which can injure their skin, that's going to count big. So it's a safety skill. Safety is always in the details. So even though it's a short skill and it's an easy skill, we're walking somebody, it's also a frequently failed skill because safety is in the details.
So I know that you would possibly holding on to the belt,
Mm-hmm.
but any
So let's talk about that for just a second, okay? If my patient starts to go wonky on me, I'm probably going to feel it before I see it. So patients, okay, here's the thing. Most people don't, because we watch way too many cartoons in our time, right? People don't just walk along, I'm good, I'm fine. If it doesn't happen like that. Patients will give you a clue that something is going horribly wrong in their lives. Now, usually it's not verbal. Very few times will patients say, oh my gosh, I'm not feeling right. they will try to rationalize it because they know you have a job to do. We're supposed to be walking. My body is not cooperating, but I don't want anybody to know that. So I'm going to try to hide it. Right. So the patient's body is going to tell you that things are going way wonky before their lips will. Now, when I'm holding that belt, I can feel them slow down. That'll be the first thing that happens. They might start to do this, list to one side or the other. They may get a little softer in the knees. So my hand that's here might actually be a little higher on their body if they're getting a little soft in the knees. The next thing that's going to happen is their hand will move. Hands either go out to the wall for stability, to their stomach because they're nauseous, or to their head because they're dizzy. They do this unconsciously without being aware that they've done it. So the first thing is their body is going to tell me something is wonky. The second thing is their hand is going to tell me where. Stability, nausea, dizzy. It's universal. Okay. The third thing is my eyes are going to tell me if they're pale, sweaty, flushed. So I need to be using all of my senses. But the very first one always comes through the hand. Always. Now, if you can pick up on this, right? If you notice patient starts to slow down, they start to get a little wobbly, they get a little soft in the knees. If you can pick that up right then, you can actually prevent a fall. Now, this is where things go horribly wrong, though. Horribly wrong. Because your first instinct is going to get them back to safety. You feel them going a little weird on you, right? You want them back in the chair as soon as possible because you don't want them to what? Fall. Guys, they aren't tolerating a slow walk. What makes you think they're going to be able to run? Right? Your expectation of what they're going to be able to do is way off here. You are not going to get them back to that chair. That chair is not an option for you. Forget it exists. So if we don't want them to fall on the floor, the best thing to do is to get them to sit on the floor, because if they're sitting on the floor, they can't fall on it. So where should you put them if they get wonky? On the floor. Absolutely. Turn them around against the wall, help them slide down. Use your body. When you're walking somebody, right, if you notice how I was walking, my hand was here and I'm walking slightly behind. The first wiggle I feel on this patient, this foot gets planted right in between theirs. It's instinct. I don't even have to think about it. When we're walking along, if she starts to do this, my foot goes here and I'm pulling her back against me because I am a stabilizing force. And then I can just slide her down to the floor. Okay, so that's why you have to be behind them and to one side. Now, if I'm directly behind, there's not much I can do. But if I'm off to one side a little bit, man, it's just super easy. 1, 2, 3, we're down. I'm going to go find myself a nurse because that's not my problem. Right? Remember, routine tasks on stable patients. Depends on where you're at. Okay. Usually, generally speaking, most of the time, most settings, you're not the only person in the hallway. Right? So you're calling for another CNA, whoever happens to be around. Yeah, I know. Yeah. So you want to try to get somebody's attention. You don't want to leave them if at all possible. I have in the past, I've sent other patients to the nurse's station. Go get me a nurse right away. Absolutely. So I don't have, and you guys, you all know you have that, a patient hanging out in the hallway that can wheel themselves down to the nurse's station. So you can send patients, that's fine. You can call loudly for a nurse, that's fine. Most of us have phones in our pockets, facility phones that we can call the operator and say, hey, call a code. I got a patient on the floor. You've got resources. You just need to figure out how to use them. Back when we didn't have phone systems in the facility, this became a little bit more problematic. We used to yell down the hallway. I need a nurse, stat. Yeah. But, you do have a phone in your pocket, a facility phone. So you can use that. But if you've got a patient sitting on the floor, is that routine? Is that stable? Is that you? That's right. That's right. It's not me. Sorry. My boxes are not checked on this one. That's your problem. It's why they pay you the big bucks. Not my patient. Good. So this skill is not hard. It's a short skill, but safety is in the details. So that means that every step of this thing is going to count. Every single step. So be careful with this one. And we just learned our last principle. You're all done. Yeah. You have now learned everything on that back wall. Every single thing. You look skeptical. Let's find out. How do we know what to do with each patient? Okay. So we follow the care plan, the whole care plan, and nothing but the care plan. What if we can't follow the care plan? Who do we tell? What if we notice something while we're following the care plan? Who do we tell? The nurse. All right. So we know skill rules. Every skill starts with an opening. Every opening starts with a knock. Very good. How do you identify your patient? Okay, call them by name. Yeah, absolutely. Yeah, you identify your patient by calling them by name. If your facility has armbands and you use them, that's part of your policy and procedure. You can use that. That's fine. But for the test, you just call them by name. But what do they need to know about you? Okay. Name and title. That's right. You are a random stranger off the street that is there to do them harm until they know otherwise. It is that simple. It is that simple. Once you've told them who you are and what you are, you need to tell them what you're going to do with them. What do you need to get from them? Permission. That's right. Do they have the right to say no? Yes. Even in a hospital? Yes. Okay. Once you've gotten permission, you're going to close the curtain, and that curtain is dirty. So what do you want to do? Wash your hands. Then you can go get your supplies, because clean hands have to be gotten with, clean supplies have to be gotten with clean hands. All right, but you need a place to put those supplies. Where are you going to put them? A barrier, because the table is not clean. All right, so you put a barrier down, you go get your supplies. That's fine. How does the barrier go on the table? Absorbent side, up or down? Up. Yeah, absorbent side up. Very good. Okay. While you're getting the supplies, they should not touch your uniform. Okay. And while you're getting supplies, you got to figure out, do you need gloves? Do you need gloves for this? How do we know? We have 3 questions. Ooey gooey. Personal skin. Yeah, personal skin. And open wounds. Right. So if the patient has any of those that you're going to touch, do you need gloves? Yes. If the answer to any of those is maybe, do you need gloves? Yes. If the answer is no, do you need gloves? No. Why can't we wear them all the time without thinking about it? Yeah, because we're not thinking about it. We end up cross-contaminating without thinking about it. That's right. So wear gloves when it's indicated. If you don't need them, wash your hands good. The first thing the gloves should touch is the patient. Right. Don't get your gloves all dirty and try to stick them in somebody's mouth. They're going to bite them off. But once your gloves are contaminated, have touched the patient, you got to be careful about what you're touching in the environment. Don't cross-contaminate. part of that is going to be graded under how you remove the gloves. So how do we remove soiled gloves? Pinch it up. Underneath. Very good. Very good. All right. If the patient is uncovered or undressed, when we need privacy blanket. That's right. And that's there to keep them warm, but also to, yeah, protect them from who? Us. We are the stranger in the room. Never forget, you are a stranger. Stranger danger. Okay. When you put the privacy blanket on the patient, you're going to pull the sheet down underneath. That way they're always covered. And then at the end of the skill, when we want to take that privacy blanket back away, how do we do that? Okay, very good. What should we not do when we're dealing with linens like blankets? Okay, so let it touch the floor, shake it or snap it. Very good, very good. So we've learned that things can't touch our uniform because our uniform isn't clean. And we know that we have to have clean hands to get clean supplies. We know that. Supplies can't touch our uniform or the floor. We've talked about that too. But if we don't use the supplies that we get, what do we do with them? It's contaminated. That's right. You cannot put it back in clean supply. Clean rolls toward me, dirty rolls away. And that applies to everything, whether it's a chucks that we're putting on the bed, whether it's a dirty sheet, whatever. It's clean rolls toward me, dirty rolls away. If you're going to move a patient, where should they be at the end of the skill when everything's in the middle of the bed? Doesn't matter whether they're on their back or their side or whatever, they have to be in the middle of the bed. Now, if you're going to turn them onto their side, that means you've got to scoot them towards you first and then turn them. Where should you be after the turn? Behind the behind. Yeah. Don't forget that.
What if the patient is fairly large?
Mhm.
And I can't scoop up.
Ideally, they should be in a bariatric bed that has more space to it, ideally, but sometimes we don't always have those available. In that case, you need a second coworker. Yeah. Because if they can't scoot off the bed, that means that when you roll them, they're going to be on the edge of or off the bed. So you have no room there to work. So you definitely need a second coworker and probably a side rail situation while you're changing them. But remember, side rails can fail, especially with a lot of weight pressed against it. So that's a very risky thing. I would honestly consult the care plan. That's something that I would, as a nurse, if I saw that. And I used to take care of morbidly obese patients, 600, 700, 800 pounds, when they were having their gastric bypasses done. I did this up in Crystal River, did home care for these individuals for months. I would see them for 6 months before and then 6 months after. And we had a lot of bed-bound, very, very large patients that when I wrote the care plans up, I had to address that. So I know what you're talking about, but it really needs to be addressed on a case-by-case basis because it depends on what I've got to work with in the environment and who I've got to work with. Because in home care, there wasn't a second caregiver, so we had to figure that out. So I can't give you the answer you're looking for because it's more of an individual thing, okay? If I'm going to wash something, whatever I wash, I rinse. Whatever I rinse, I dry. Yeah, it's really easy to miss a step. Really easy to miss a step. So in your brain, you should be saying those steps as you're doing them to keep you on track, because otherwise you'll forget something. If I'm going to wash a wet body, oh, we haven't got to that yet. That's today. Okay, we'll talk about that in a minute. How do I know that the water is a good temperature? Okay, what should the temperature be? Warm, not hot, not cold, just warm. And who else checks it? The patient checks it. Okay. When we're washing stuff, we want to try not to get our surface wet. So make sure your washcloths are wrung out really well. Don't have a drippy, wet, icky washcloth, right? Where does the soap go? In the basin? On the washcloth. Good. Very good. Why? Why? Right. You need water for rinsing. Very good. Trick question. You guys pass. Okay. If you put lotion on, you're going to warm it up first. And then what do you do after you put it on? Rub the excess off. Okay. We clean everything the same way, especially things that have held washing water, right? How do we know where to dump stuff from our basin? Okay, where it normally goes. Yeah, just think about where it would normally go. Okay. All right. So we're going to empty the basin and then we're going to rinse it. And for the test, we do not disinfect anything, but we have to have a process that allows for disinfection. So after we rinse that basin out and dump it out, we're going to set it down in the sink. Okay. So can I now pick that basin up with I need a paper towel. That's right. So it doesn't make any sense if we didn't disinfect. Like, why are we doing that? But the whole process is in place so that when we do disinfect, we know exactly how to do it. Okay. So paper towel to pick it up, paper towel to dry the inside. Is the outside of anything considered clean? No. So we need a different paper towel to dry the outside. And then I got to put it away. Can I touch that drawer with my dirty hand or dirty glove? So what do I need? So you guys should all buy stock in paper towels, is what I'm telling you, because we use a lot of them, right? Okay. If the patient's feet hit the floor, we have to talk about their shoes. Why are slipper socks not enough? Okay, they slide. Okay, so they don't protect against slit or punctures, sharp objects. What else? Pathogens. Man, those ooey gooeys are everywhere, man. You'd be surprised. If I flashed a black light around, oh my gosh, place would light up like Christmas. It's true. And I'm not dissing housekeeping. Housekeeping does a fantastic job. They really do. But it doesn't mean that there aren't pathogens still out there, right? So we got to protect our patients. How do we know a gait belt is tight enough? 4 fingers. Okay. Before I stand a patient up, I need to make sure their feet are flat on the floor and, yep, comfortable. Yep. Now, when I go to stand them up, how do I know they're ready to stand? Count. Okay. All right. And where should I be when I'm walking them? Okay, behind and beside. And I should be watching for anything that gives me a clue that something's going terribly wrong in my world. If something does go wrong, where am I putting the patient? On the floor, and find somebody who cares. Yeah. All right, so I'm finally done with all of my skills. Woohoo, yay, good job. So we got to finish this out. There's 4 C's that we don't care about the order on. Comfort. Okay, so comfort, curtain, call, light, clean. Those 4 we don't care about the order. Just get them all done. Who cares? Right? And then we need to hear that word comfortable. Please remember that. Magazine is part of comfort. Once you get all 4 of those done, doesn't matter the order, nobody cares. Then you're going to go clean your hands because you touch that curtain and you touch that call light and you touch the patient and you got all kinds of cooties all over you. There's another C, right? You got to take the cooties off. And then you're going to chart if necessary. Now, not all skills require charting. In fact, there's only 4 skills that we learned that do. So once you chart, what else do you have to do? Clean your hands again. Good. So we just went through every single one of those banners, guys. Every single one of them. And we're only half done. So imagine what else I have to teach you. Right. So lots of stuff that we've learned. Think about how far you've come in 2 weeks. Okay, you should be proud of yourself. This is a big accomplishment. And I know that you're not just going to pass the test, you're going to go on to be stellar caregivers, which is what I care about, because that's the real test. That's the real test, right? So I know you guys are all going to be fantastic, and you will pass the test. No, you will. You will pass the test because you're going to hear me in your brain. Yeah, you.
I've heard you. Fell in the dryer.
Yep. Yeah, it's funny. My husband will throw these things back at me, right? He's not in healthcare at all, but every once in a while, like if I pull sheets out of the floor and it touches the ground, he's like, "You better rewash that." You know that doesn't fly. So yeah, I am omnipresent. I am everywhere. Yeah. All right. So everybody good? Good. Okay, let's go to page 55, please. Okay, so this is a range of motion skill. Right. So there's 3 exercises that we can do as CNAs. Flexion extension was up and down. Abduction, abduction, adduction is side to side, and rotation is around. Okay. But we don't do all exercises on all body parts. How do we know which exercises to do on which body parts? Care plan. So our care plan at the top, page 55, says, provide the following range of motion exercise to the resident's right elbow and right wrist, flexion extension. Provide 3 repetitions of each exercise, and the resident is not able to help with the exercises. So we have our recipe here. We're going to do flexion extension, which is up, down, to the elbow 3 times, and to the wrist 3 times. Guys, the elbow only moves in one direction. It's a hinge joint. If you get an elbow to do anything other than this, you broke it. Okay. That's all it does. Up, down. That's it. All day long. Now, the wrist can go in all different directions. The wrist is an articulating joint, which means it can go up, down. It can go side to side. It can go around. It can do a lot of stuff. But the care plan just tells us to do up, down, flexion extension. So this skill, we do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I need to do some exercises. Is that okay? Close curtain, wash hands. Bend the elbow up and down like you're making a muscle 3 times. Make sure it's supported on the bed. Remember, that elbow always has to be supported either on the bed or in your hand, right? Up, down, 3 times. And then the wrist is going to go up, down like you're revving a motorcycle 3 times. Yeah, I lift it up so the elbow's on the bed just to make it a little bit easier so I don't have to bend. Okay, up, down, right? That's it. Do a closing at the end. That's the whole skill. That is it. Man, I want that skill. Now, I'm going to tell you, the one skill that you dread is one you will get. I do not understand how it works, but something in the cosmos, and it's true. Students have told me for years that the one skill they did not want is one that they ended up getting. And I don't know how it works. I think there's something to that law of attraction, although I keep playing the lottery and it never works for me. But if you're going to dread something, dread this one. Dread this one, because you will get the one that you dread. Okay, so let me show you what this looks like. Let me get a volunteer, somebody to come lay down in the bed. Can you turn that camera for me to face the bed, please? I know. Keep going. 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 That's good. Thank you. I know. I can't wait to get the panning thing. I'm sorry to put you to work. Okay, so which wrist, if I'm getting ready to start this skill, right? And I can't remember what the care plan said, right or left, which one should I do? Good job. Good job. So this care plan tells me to do the right wrist. Okay. Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to do some exercises on your right elbow and wrist. Is that okay? All right. I'm going to close your curtain, go wash my hands, and I'll be right back. Before I do that, can I get you to lift up for me, please? I don't want you to, there we go. I don't want that to hurt you. So I'm going to close the curtain. I have clean hands. Remember, my right and left is different from his when I'm facing him. So I've got to make sure I'm on the correct side. This is his right. All right, Mr. Jones, I'm going to do all the work here. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is bend your arm up and down like you're making a muscle. So I'm going to put your hand palm up, and we're going to go up and all the way back to the bed. Feel okay? Any pain? Okay, up, all the way back. That's 2. One more. Up and all the way back. Feel all right? Okay, so now we're going to move on to the wrist, and we're going to go up and down like you're revving a motorcycle. So loose fist. We're going to go forward and back. Feel that stretch? Feel okay? We're going to go forward and back. That's 2. One more. Forward and back. That's 3. Good. Any pain or discomfort? Are you comfortable? Okay. Can I get you anything before I go? A magazine? I'm good. Okay. Let me come around to the other side to give you your call light. My environment's clean. I'm going to give them the call light. Here you go. If you need anything at all, just let me know. Hit the red button. I look around. Everything's good. I've washed my hands. My skill is done. It's the whole skill. I want that one. Thank you. Questions? No? Okay, now go to page 86. Okay, how do we know what to do with each patient? All right, go ahead and read the care plan at the top of the page, and I'll be with you in just a moment. Yeah, we're not massage therapists. I'm going to get to that in just a minute. But we are going to give a little back rub. You take one and pass it around, please. All right, so this care plan is ridiculously detailed. Oh, can you play cameraman one more time, please, and turn it this way? This will be the last time, I promise, for today. Keep coming, keep coming. That's good. All right. So this care plan is ridiculously detailed. It tells us to give the resident a partial bed bath. So we're going to stop there for a second. Partial. That means that we're not washing the entire body, a part of it. But yeah. But if it's a part of a body, we need to know what parts. You know, I mean, that's not universal. That just means that we're not washing the whole thing. So it's got to be pretty detailed to tell us what parts we're supposed to wash. So it goes on to tell us, wash the resident's face, neck, chest, abdomen, back, one arm and hand with soap and water. So the easy way to remember this, guys, is face to waist, face to waist, one arm and hand. And we're going to wash the face first, no soap on the face. Soap gets into the eyes and it stings really bad. We don't want to do that. So face first, no soap on the face. Good. Questions? Okay, so this is super easy, guys. We're going to wash the face. No soap. We're going to dry. We're going to wash the torso and the hand closest to us, the arm closest to us. Whatever we wash, whatever we rinse, okay. And then we're going to, well, hold on 1 second. It says to dress the resident in a hospital gown. So we're going to put a new hospital gown on. We're going to turn the patient over and wash the back, rinse the back, and dry the back. And since we already have the gown on, when we're all done, we're going to give them a back rub and then tie that gown so we don't have to turn them again at the end of this, dress them and turn them again. This helps with energy conservation. Remember, we talked about energy, right? So if you wash the front, rinse the front, dry the front, put the gown on, and then turn them on their side, wash, rinse, and dry the back, give the back rub with lotion and wipe off the excess. All you have to do is tie that gown. Easy. Good. Okay, but we're going to learn a new cleaning method, something that you guys are not familiar with. And that's called the leaves method. Now we're going to use this leaves method anytime we're washing wet body openings. So a wet body opening would be like an eye, right? That's an area that stuff can come out. Nose, mouth, genitals, rectal area, wounds, rashes, sores, and incisions. So basically, if it's not intact skin, we probably need to use, well, we're going to need gloves for sure, but we need to use a bathing method that does not allow pathogens in or out. Good? Make sense? So we use the leaves method. Now, if you turn the page to 85, this is what I'm talking about. In order to understand this, we have to have a brief conversation about the chain of infection. So when it comes to pathogens, you probably have some misconceptions. Pathogens don't fly, they don't crawl, they don't creep, they don't move at all. They pretty much stay where you put them, unless they have a way to get around. So a pathogen needs a vehicle. It's kind of like somebody stuck at home with no car, right? It's got to get a ride somewhere. So if you have a pathogen and it's inside somebody's body, it's safe there unless it finds a doorway out, right? If you've got hepatitis C in you, you're keeping it to yourself as long as you don't have any doorways that are open. Okay. But if he gets a cut on his hand and he starts to bleed, now he's got a doorway. So that hep C is no longer safe inside of you. It is cruising. Now, you are still pretty safe because you're way over there. It needs a way to get from you to, the table to you. So it needs a vehicle. It needs a way of getting, it doesn't fly. It doesn't float, nothing like that. And the most common vehicle are hands. Okay. But even that's not a problem, because as long as your skin is intact, that hep C is on your skin, not in you. It can't burrow. It doesn't drill. It's just a pathogen on you. But the problem is that our hands generally go up to our faces. Yeah, about 20 times an hour. I mean, think about it. You've got your hand at your face. You just wiped your mouth. So it happens without us even being aware of it. It's an unconscious gesture. So generally speaking, that pathogen isn't going to have to wait around long before it finds a doorway in. And now that it's inside me, it can be a problem as long as I'm susceptible. Now, if I've been all vaccinated up and my immune system knows how to get rid of this thing, it's not a problem for me. But if I'm susceptible, now I'm the guy with the hep C inside that's safe inside of me, as long as it doesn't have a doorway out, unless I have a cut and bleed, and somebody else encounters it. You see how this whole chain of infection goes? Okay. So we need to understand that our eyes, our nose, our mouth, these are all doorways. It's places that things can come in and go out. So if I'm washing an eye, I don't want anything that came out of that eye to go into another eye. Good. So that's what the leaves method is all about. So this is a plain washcloth, square washcloth. You probably have these at home. I put one in front of you. Fold it in half and in half again. This is how we store them most of the time, just in these little squares, folded squares, right? But instead of looking at it as a square, which is how most of us look at it, I mean, it is a square, right? If you turn it a quarter turn, it becomes a diamond. And that's how I want to think about this. This is a diamond. Now, if you hold the diamond so the free edges are pointing up, and you tuck one side between your pinky and your ring finger, and the other corner between your thumb and index finger like this, you can wipe something. I'm going to come around and help you guys. You can wipe something, and then we're going to fold that leaf down, which traps the contamination underneath. Now we can wipe another something and fold that leaf down, which traps the contamination underneath. And now we can wipe the nose and fold that down, which traps the contamination underneath. And then we can wash the mouth, which traps the contamination underneath. So we have 5 independent cleaning surfaces on this washcloth that will not cross-contaminate. And this is called the leaves method because we use one leaf for every wet body opening, every stroke. That way we're not taking stuff from one area and depositing it in another. Good. So the way you do this is you hold the washcloth so the free edges point up, and you put it on your hand just like that. So your hand is behind it. You tuck one corner in over here and one corner in there. And that allows you to wash. Yep. Just like that. Pretty cool. I use this with my kids all the time when they were little. This is an awesome trick to learn. Okay. Good. All right. So go back to our care plan. It says give the resident a partial bed bath and a back rub. We are not massage therapists. We don't deep tissue anything. Not our job. People go to school for a year to learn how to do that. That's not us. We are giving a back rub for circulation. All we're trying to do is wake up the capillaries and the nerve endings. So this is just 3 passes. That's all we care about. Okay. Remember when you were little and you got sick, mom probably came along, kind of rubbed your back a little bit, and it always made you feel a little bit better. That's what we're doing here. Okay. Not trying to work out any knots or anything like that. So we need, because we're wearing gloves, remember we are touching wet body openings, ooey gooey. So we need some gloves for this. We're also touching personal skin. We need some gloves for this, but you don't want gloves on skin because it's a lot of friction. So we need some lotion. So a little lotion in our hand, warm it up. And we're going to do small circles from the bottom of the back up to the shoulders 3 times, up to the shoulders 3 times. There we go. Now we put lotion on. We're going to wipe off the excess, tie the gown, clean up, do our closing, and we're done. This is the longest skill that we do. If you look at the bottom of the page, you'll see that it can take somebody with your level of experience up to 19 minutes to do this skill. That is a super long skill, guys. The good news is if you get this one for the test, you get 2 super short skills to go with it, like range of motion and respirations. 2 super short skills to go with it. And you already know all the steps here. There's nothing new to teach you a partial bed bath other than the leaves method. You know all the steps. You know how to do the opening. You know how to use a barrier. You know when to evaluate glove rules, and we're going to need gloves for this. If the patient's uncovered or undressed, we need a. If you get supplies, you don't want to hold them against your. I mean, you know this, guys. Whatever we wash, we rinse. Whatever we rinse, we dry. We're going to check the water temperature. They're going to check the water temperature. You know all this. There is nothing new to teach you. If you're going to turn a patient on their side, you got to scoot them towards you first. You know all the steps here. Okay. It's a long skill, but it's not an unfamiliar one. Good. Questions? All right, let me show you the video. Questions? You want to try to keep them as covered as possible. But sometimes you're going to have to move the blank, to be able to see, visualize. Because a lot of times, especially with larger breasts, there can be fungal infections or sores underneath. So in that case, you would fold the blanket down and lift. When you're lifting breasts, you want to lift with the back of your hand from below, not cup. So you're going to lift up. Same thing with a male scrotum. You want to lift with the back of your hand to clean around. Mhm. Mhm. Under it and lift right with the back of your hand. Yep. Yeah, it's a mannequin. Yeah. And their mannequin, or, the mannequin's breast just sticks straight up. So it's, not like real life at all. All right. So tonight you have chapter 7 to do in homework. Chapter 7 is a lot like 6. So read the paragraphs in between the skills. You would, however, my printer does not seem, it's Monday, and my printer does not seem to want to work. So I will have to give that to you on Wednesday once I can figure out what's wrong with my printer now. Okay. Those of you that are joining us online, the review sheet is actually online from, on this particular class. All right, you guys are dismissed. I will see you on Wednesday. Have a fantastic day. Hopefully Wednesday will go a little smoother. Bye-bye. Have a good day.